Hello and welcome to the lecture on Chapter 17 in your text, Endocrine and Hematologic Emergencies. After you complete this chapter and all related coursework, you will understand the significance and characteristics of diabetes, sickle cell disease, clotting disorders, and the complications associated with each. You should be able to demonstrate knowledge of the characteristics of type 1 and type 2 diabetes, and you should be able to list the appropriate steps for assessment and pre-hospital management and treatment of diabetic emergencies. You should also be able to discuss hematologic emergencies and describe the four main types of sickle cell crises: vaso-occlusive, aplastic, hemolytic, and splenic sequestration, and the two primary types of clotting disorders, thrombophilia and hemophilia. Regarding the National EMS Education Standard Competencies for Medicine, the EMT will apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. Specifically regarding the endocrine system, you will have an awareness that diabetic emergencies can cause altered mentation, and you will understand the anatomy, physiology, pathophysiology, assessment, and management of acute diabetic emergencies. Regarding hematology, you will understand the anatomy, physiology, pathophysiology, assessment, and management of sickle cell crisis and clotting disorders. The human endocrine system affects nearly every cell, organ, and bodily function, and endocrine disorders can have many signs and symptoms. Hematologic emergencies have the following characteristics. They are very rare in most EMS systems. They are very difficult to assess and treat. And most of the time, all we can do as field providers are offer support, and that may save the patient's life. The endocrine system is a complex message and control system. Endocrine glands secrete hormones. Endo means inside. Hormones are chemical messengers. They have special regulatory effects on organs and tissues. The main function of the endocrine system is to maintain homeostasis, which is stability in the body's internal environment. This involves responding to any change in the body, such as low glucose or calcium levels in the blood. Homeostasis can be disturbed by hypersecretion, overproduction, or hyposecretion, underproduction of a gland. Diabetes pathophysiology. Diabetes is a metabolic disorder involving abnormalities in the body's ability to use glucose for fuel. It affects about 7% of the population, and it can have severe complications such as blindness, cardiovascular disease, and kidney failure. As an EMT, you need to know the signs and symptoms of a blood glucose level that is high, called hyperglycemia, and this can result in coma or death. If treatment exceeds a patient's need, it can cause a life-threatening state of hypoglycemia, which is low. The central problem in diabetes is the lack of insulin or ineffective action of insulin. Glucose or dextrose is the primary fuel for cellular metabolism, and insulin is a hormone that is normally produced by the endocrine glands or on the pancreas that enables glucose to enter the cells. Diabetes mellitus, which is diabetes' full name, means sweet diabetes, which refers to the presence of wasted glucose in the urine. Diabetes insipidus is a rare condition involving excessive urination. The hormone that regulates urinary fluid reabsorption is missing, and that's what causes this process. There are two types of diabetes, both of which are equally serious. Both can affect many tissues and functions other than the body's glucose regulating mechanism, and both require lifelong medical management. Type 1 diabetes patients do not produce insulin. Patients need daily injections of supplemental synthetic insulin, and in the past we have referred to these patients as insulin-dependent diabetes mellitus. Typically, it develops during childhood, and it's called juvenile onset diabetes, though it can also develop later in life. Patients more likely to have metabolic problems and organ damage like blindness, heart disease, kidney failure, and nerve disorders. It is considered an autoimmune problem because the body is allergic to and destroys insulin-producing cells of the pancreas and endocrine glands. Type 2 diabetes patients produce inadequate amounts of insulin, or a normal amount that does not function effectively. This usually appears later in life, and treatment may consist of diet, exercise, oral medications called hypoglycemic agents, or supplemental insulin. Non-insulin type oral medications stimulate the pancreas to produce more insulin, and some of these are diabetes, Oronese, Micronese, Glucotrol, Glucophage, and Avandia. Hypoglycemic agent administration may cause hypoglycemia in some patients, for example, those who are very active or who exercise a lot. In the past, it's been referred to as non-insulin dependent diabetes mellitus or adult onset diabetes. Some patients, however, may still require insulin, and this type of diabetes is easier to regulate and is much more common. The severity of diabetic complications depends on how high a patient's average blood glucose level is and how early in life diabetes began. And obesity increases the risk. Glucose and insulin supply the body with the energy necessary for its cells to function. Glucose is a major source of energy for the body, and without a constant sufficient supply, brain cells will rapidly suffer permanent damage. Insulin is needed to allow glucose to enter the cells, with the exception of the brain. This is said to be a cellular key. Without insulin, glucose from food remains in the blood and glucose levels become too high. This is called hyperglycemia. Once glucose levels reach twice the normal amount, and normal is considered 80 to 120, the excess will be excreted by the kidneys. And this just is a great schematic that shows the role of glucose and insulin. Pancreas produces the insulin. Insulin allows glucose to enter and nourish the cells, and without it, glucose cannot enter the cells to meet the body's need. The classic symptoms of uncontrolled diabetes are as follows. We call them the 3 Ps. Polyuria, frequent plentiful urination; polydipsia, frequent drinking to satisfy continuous thirst; and polyphagia, which is excessive eating as a result of cellular hunger, but this is rare. When glucose is unavailable to the cells, the body turns to other fuel sources. Fat is the most abundant source of energy, and ketones and fatty acids accumulate in blood and tissue, causing acidosis when fat is used for energy. Diabetic ketoacidosis is a form of acidosis seen in uncontrolled diabetes. Without insulin, certain acids accumulate, and this is more common in type 1, and the signs and symptoms include weakness and nausea, a weak rapid pulse, Kussmaul's respirations, which blows off excess acids, a sweet-smelling breath caused by the ketones, and altered mental status. Without proper fluid and insulin to reverse fat metabolism and restore glucose use for energy, DKA can progress to coma and death. Type 2 diabetes more often results in hyperosmolar hyperglycemic non-ketotic coma, called HHNC. It is slower, more gradual onset than DKA. The sweet smell is not present because the body does not burn fat for energy, and the body tries to get rid of excess sugar through urine, causing dehydration. In some systems, EMTs are allowed to use glucometers to monitor patients' blood glucose levels. The treatment must be tailored to each patient's need for glucose. Most type 1 patients use glucometers several times a day to monitor their blood glucose levels, and the device analyzes a drop of blood, usually from a fingertip, on a disposable sensor. The newer devices that are in development can be worn like a wristwatch or a pulse oximeter. Glucose test strips are also used in some EMS systems, where a drop of blood is placed on a paper strip, and this is less accurate than the glucometer with the finger stick. Both hyperglycemia and hypoglycemia can lead to a diabetic emergency. The result of a lack of insulin, which causes excessive amounts of glucose to remain in the blood, and if untreated, it results in DKA. The signs and symptoms include history, excessive food intake, insufficient insulin dosage, gradual onset, hours to days, warm, dry skin, and infection. The GI tract, you'll see dehydration, lack of appetite, weakness, nausea, and vomiting. Respiratory, we'll see rapid, deep respirations called Kussmaul's respirations, and we may notice a sweet, fruity breath odor. The cardiovascular system will have a normal to low blood pressure, a rapid, weak, thready pulse. The nervous system, the patient will be restless. They may possibly progress to coma, and they may have abnormal or slurred speech and an unsteady gait. In response to treatment, gradually 6 to 12 hours following medical treatment, these symptoms will improve. Hypoglycemia, on the other hand, is a state in which the blood glucose is below normal. Untreated, it results in unresponsiveness and eventually hypoglycemic crisis. The signs and symptoms include, on history, an insufficient food intake, an excessive dose of insulin, rapid onset in minutes, and pale, cool, moist skin. The GI tract, absence of thirst and intense hunger. Respiratory system, normal to shallow or rapid respirations. The cardiovascular system, normal to low blood pressure and a rapid, weak pulse. The nervous system, altered mental status, aggressive, confused, lethargic, or unusual, seizures, fainting or coma, unsteady gait, weakness on one side of the body which may mimic a stroke. The signs and symptoms of hyperglycemia and hypoglycemia can be quite similar, and this is seen on Table 17-1. It is not uncommon for either of these patients to have a staggering, intoxicated appearance or be completely unresponsive. Hyperglycemic crisis or diabetic coma is a state of unconsciousness resulting from DKA, hyperglycemia, and/or dehydration due to excessive urination. On some occasions, excess blood glucose by itself can lead to hyperglycemic crisis. It can occur in diabetic patients who may not be under medical treatment, who have taken insufficient insulin, or who have markedly overeaten, or may be under stress related to infection, illness, overexertion, fatigue, or alcohol consumption. If untreated, it can result in death, and treatment may take hours in a well-controlled hospital setting. These patients require transport. Hypoglycemic crisis or insulin shock is a result of insufficient levels of glucose in the blood. It can occur when insulin-dependent patients take too much insulin, take a regular dose of insulin but have not eaten enough food, engage in vigorous activity and use up all of their available glucose, vomit a meal after taking a regular dose of insulin. There may not be enough glucose to supply the brain, and we need to treat quickly to avoid brain damage. If untreated, it can produce unconsciousness and death, and the condition is quickly reversed by giving the patient glucose. Diabetic patient assessment. We follow the same steps like anything else. Perform a scene size-up, perform a primary assessment, take a history, perform a secondary assessment, and then reassess our patient. Scene safety. Diabetic patients often use syringes for insulin, so you need to be careful of the presence of syringes and make sure that you use proper precautions. Be alert for clues. For example, syringes, insulin bottles, plate of food, glass of orange juice, that this is a diabetic emergency. Determine the number of patients involved, use gloves and eye protection, and consider the need for additional resources. Determine the mechanism of injury, nature of the illness, and remember, trauma may also be a factor. Perform your primary assessment. Get your general impression. Do your rapid scan. Look at their appearance. Are they anxious, restless, or listless? Are they apathetic or irritable? Are they interacting appropriately with the environment? Identify any life threats and provide life-saving interventions, particularly airway management. Determine level of consciousness using the AVPU, alert to person, place, and day, responsive to verbal, responsive to pain, or unresponsive scale. If unresponsive, call for ALS. The patient may have undiagnosed diabetes. If they have altered mental status, assess their blood glucose if you have the proper equipment and training. Perform C-spine stabilization if necessary and provide rapid transport. Remember, always carry out a thorough, careful primary assessment, paying particular attention to the ABCs. Other medical or trauma emergencies may be responsible for a diabetic patient's signs and symptoms. Assess the airway and breathing. Patients showing signs of inadequate breathing or altered mental status should receive high-flow oxygen via a non-rebreather. Hyperglycemic patients will have rapid, deep Kussmaul's respirations with a sweet, fruity breath. Hypoglycemic patients will have normal or shallow to rapid respirations. If they're in respiratory distress or arrest, you need to open the airway and insert an adjunct, administer oxygen and assist ventilations, and continue to monitor ventilations throughout patient care. Assess this patient's circulation. If their skin is dry and warm, they're probably hyperglycemic. If they're moist and pale, they're probably hypoglycemic. If they have a rapid, weak pulse, they may be in hyperglycemic crisis. Make your transport decision. Unconscious patients or patients with altered mentation and impaired ability to swallow should be transported promptly. Patients capable of swallowing and conscious enough to maintain their own airway may be further evaluated on scene and intervention performed. History taking. Investigate the chief complaint. Obtain a history of the present illness from responsive patients, family, or bystanders. Responsive diabetic patients will often know what's wrong. If the patient has eaten but not taken insulin, hyperglycemia is more likely. If the patient has taken insulin but not eaten, hypoglycemia is more likely. Observe physical signs and symptoms to determine whether the patient is hyperglycemic or hypoglycemic. Obtain the sample history from the responsive patient or a family member, And for a known diabetic, ask, do you take insulin or pills to lower your blood sugar? Have you taken your usual dose of insulin or your meds today? Have you eaten normally today? Have you had any illness, unusual amount of activity, or stress? And look for an emergency medical identification device like a wallet, card, necklace, or bracelet. Secondary assessment. Perform your physical exam by doing a full body scan. You should look for clues about the patient's condition and be alert for secondary signs of injury or illness. For example, trauma that may be caused by altered level of consciousness in a fall. For known diabetics, focus on their mental status, their ability to swallow, and ability to protect their airway, and obtain a Glasgow Coma score. Vital signs including a blood glucose. Use a glucometer if available and protocols allow. Study the operator's manual for proper use in the field. Know the upper and lower ranges at which your glucometer functions. The normal adult blood glucose range is 80 to 120. You should also use a pulse oximeter to assess perfusion. And it can assist in identifying a degree of respiratory distress. Reassess your patient. Reassess the diabetic patient frequently to assess changes. Has their mental status improved? Are their ABCs intact? How is the patient reacting to any interventions I've performed? Provide the indicated interventions. If your patient is hypoglycemic and conscious and they can swallow without the risk of aspiration or inhalation of a substance, then you should encourage the patient to drink juice containing sugar. You can also administer high concentrated sugar gel called oral glucose if local protocol permits. You may also be, under protocol, able to administer IM injections of glucagon. Provide rapid transport to the hospital. For the unconscious patient who is hypoglycemic or a patient with risk of aspiration, IV glucose or IM glucagon is needed, which EMTs are not permitted to give. Advanced EMTs and paramedics can start an IV line and administer IV glucose, and you provide rapid transport to the hospital. For an unconscious known diabetic patient, determine whether hyperglycemic or hypoglycemic. The primary difference will be their breathing. If they are experiencing Kussmaul's respirations, they are probably hyperglycemic. Seizures are more likely a sign of hypoglycemic crisis. If they're in hypoglycemic crisis, patients need sugar immediately, and you may give it if your protocols allow. If it's a hyperglycemic crisis, patients need insulin and IV fluid therapies, and EMTs, even paramedics, do not give insulin in Montana. However, we may start IV fluids. When in doubt, err on the side of giving glucose if you do not know their exact blood sugar number. Reassess your interventions. Check your patient response to what you've done currently and adjust. Coordinate your communication and documentation. Inform the receiving hospital about your pre-hospital treatment, assessment, and care, and follow local communication and documentation protocols. Oral glucose is a commercially available gel that is given to increase a patient's blood glucose level. One tube contains 1 30-gram dose. Trade names are Glucotose, Instaglucose. Follow the local protocols for glucose administration, and this is in Skill Drill 17.1. The only contraindications are the inability to swallow and unconsciousness, because aspiration may occur and you should always wear gloves before putting anything in your patient's mouth. Problems associated with diabetes. First of all, seizures. Seizures should be considered very serious even in patients with a history of chronic seizures. Though brief seizures are not harmful, they may indicate a potentially life-threatening underlying condition. Some of the possible causes include infection, poisoning, hypoglycemia, trauma, decreased levels of oxygen, idiopathic or unknown causes, fever in children, and undiagnosed epilepsy in children. Ensure that the patient's airway is clear and place them on their side so that if there's no possibility of C-spine trauma. Put nothing in the patient's mouth. For example, a bite stick or oral airway would be inappropriate. Have your suctioning equipment ready in case they vomit. And if the patient is cyanotic or appears to be breathing inadequately, provide oxygen and artificial ventilations and transport. Altered mental status may be caused by complications of diabetes like hypoglycemia or ketoacidosis. May also be from other conditions such as poisoning, head injury, postictal state, or decreased brain perfusion. Ensure that the airway is clear. Be prepared to provide artificial ventilations. Be prepared to suction if the patient vomits. And provide prompt transport. Alcoholism. Occasionally, patients with diabetic emergencies are thought to be under the influence. and the symptoms are sometimes mistaken for intoxication. A diabetic patient confined by police in a drunk tank is at risk for a severe emergency. An emergency medical identification bracelet, necklace, or card may help save the patient's life in such situations. A blood glucose test performed at the scene, if protocols allow, or in the emergency department, identifies the real problem, and be alert to the potential for diabetes and alcoholism to coexist. Patients with altered mental status can lose their gag reflex, which affects airway management. Vomit or the tongue may obstruct the airway, and you should carefully monitor the airway at this time. Place the patient in a lateral recumbent position and make sure that suction is readily available. We're going to move on now to hematologic emergencies. Hematology is the study and prevention of blood-related diseases. Blood-related diseases include sickle cell disease and hemophilia. We have to remember that blood is our fluid of life, and understanding its composition helps to understand various disorders. Blood is made up of cells in plasma. Red blood cells, or erythrocytes, contain hemoglobin, which carry oxygen to the tissues. They make up about 47% of male and 42% of female blood volume. White blood cells, or leukocytes, are the cleaners of the body. They respond to infections and dead cells. And platelets are small cells in the blood that are essential for clot formation, and they respond to blood vessel damage and stop bleeding. Plasma is the straw-colored fluid that transports red blood cells, white blood cells, and platelets throughout the body. Sickle cell disease is an inherited blood disorder that affects the red blood cells. It is predominantly found in African Americans and persons of Mediterranean descent. People with sickle cell disease have red blood cells that are oblong or sickle-shaped, contain hemoglobin S, they're poor oxygen carriers, and they live for only 16 days. This may result in lack of oxygen in body cells and tissues, known as hypoxia, because sickle cells may lodge in small blood vessels of the spleen, causing swelling, rupture, and ultimately death. Normal red blood cells are around, contain hemoglobin A. They're around, contain hemoglobin A, and live 120 days. There are 4 main types of sickle cell crisis: vaso-occlusive crisis, aplastic crisis, hemolytic crisis, and splenic sequestration crisis. In vaso-occlusive crisis, blood flow to organs is restricted, causing pain, ischemia, and organ damage, and it usually lasts 5 to 7 days. Circulation to the spleen is usually obstructed due to narrow vessels and function of removing damaged red blood cells. Aplastic crisis is a worsening of a patient's baseline anemia. Lack of circulating red blood cells in the body cause this. It causes tachycardia, pallor, and fatigue, and it may be caused by the parvovirus B19, which affects the production of new red blood cells, nearly stopping it for 2 to 3 days. Hemolytic crisis is an acute accelerated drop in hemoglobin. It's caused by red blood cells breaking down at a faster rate than normal. It's common in patients with enzyme deficiencies. And the final one is splenic sequestration crisis. It's a painful acute enlargement of the spleen, and the abdomen becomes very hard and bloated. Sickle cell disease complications. Although some take days and weeks to develop, some complications are acute and life-threatening. For example, cerebral vascular attack, gallstones, jaundice, avascular necrosis, splenic infections, osteomyelitis, opiate tolerance, and leg ulcers, retinopathy, chronic pain, pulmonary hypertension, and chronic renal failure. Clotting disorders. Clotting disorders are abnormalities in clotting of the blood. Thrombosis is the development of a blood clot occurring in arterial or venous blood vessels. The patient's symptoms relate to clot location, size, and whether the clot becomes dislodged and travels to another part of the body. Thrombophilia is the tendency to develop blood clots. It affects 5 to 7% of Caucasians of European descent in the United States. Thrombosis may manifest as a clot in the blood vessel or in one of the chambers of the heart. Nearly 2 million people per year experience the formation of a clot in a deep vein thrombosis in the United States. Nearly 50% of those experience long-term adverse health effects, and the leading cause of death in hospitalized patients is due to a lack of mobility. Nearly 40% experience pulmonary embolism, a complication involving a clot that travels through and obstructs blood flow to the lung. Blood-thinning medications decrease the frequency of clotting, and some of these are aspirin, heparin, or warfarin, or Coumadin. Thrombophilia is not common in pediatric patients. The risk factors include recent surgery, impaired mobility, congestive heart failure, cancer, respiratory failure, infectious diseases, age older than 40, being overweight or obese, smoking, and the use of oral contraceptives. Hemophilia is a congenital abnormality in which the body is unable to produce clots. It results in uncontrolled bleeding, and it occurs predominantly in males, about 1 in every 5 to 10,000 births. There are 2 different types of classifications, which is hemophilia A, most common, and that's because of a low level of factor VIII, and hemophilia B, which is a deficiency of factor IX. The signs and symptoms of hemophilia are A or B are the same. Spontaneous acute chronic bleeding that may or may not be life-threatening, and spontaneous intracranial bleeding that is common and is a major cause of death. When assessing hemophilia patients, seriously consider injury or illness that can cause bleeding. Patient assessment of hematologic disorders. The steps are the same. Size up the scene, primary assessment, take your history, secondary assessment, and reassess. Ensure your scene safety. Most sickle cell patients will have had a crisis before. You should wear gloves and eye protection at a minimum. Determine your number of patients, be alert for signs of trauma, and consider ALS support because these patients may need analgesic administration for vaso-occlusive crisis pain. And determine your mechanism of injury or nature of the illness. And remember, trauma may be a factor. Primary assessment. Is the patient in pain and of African American or Mediterranean descent? If yes, may have undiagnosed sickle cell disease. Perform C-spine stabilization if trauma is suspected. Form a general impression of your patient. Do your rapid scan. Is your patient anxious, restless, or listless? Is the patient apathetic or irritable? Determine level of consciousness using AVPU. Assess the patient's airway and breathing. For patients with inadequate breathing or altered mentation, provide high-flow oxygen at 12 to 15 liters via a non-rebreather mask. Patients who are in sickle cell crisis may have increased respirations or exhibit signs of pneumonia. If your patient has breathing difficulty, open the airway, insert an adjunct, and give oxygen. You may need to assist ventilations. Assess the patient's circulation. Sickle cell crisis patients will have increased pulse rate to force sickled cells through smaller vasculature. For hemophilia patient, be alert for signs of acute blood loss, like pallor, weak pulse, and hypotension. Note bleeding of unknown origin, like nosebleeds, bloody sputum, or blood in the urine or stool, and be alert for signs of hypoxia, which is due to blood loss. Make your transport decision. Take your history. Investigate your chief complaint and get a history of the present illness from responsive patient, family, or bystanders. Be alert for physical signs indicating sickle cell crisis, such as swelling of the fingers and toes, priapism, and jaundice. Include the OPQ-RST mnemonic for assessing pain. Is the pain isolated to a single location or felt throughout the body? Is the patient having any visual disturbances? Is the patient experiencing nausea, vomiting, or abdominal cramping? Is the patient experiencing chest pain or shortness of breath? Obtain the sample history from a responsive patient or family member. Have you had a crisis before? When was the last time you had a crisis? How did your last crisis resolve? Or have you had any illness, unusual amount of activity, or stress lately? Perform a secondary assessment. Focus on major joints at which cells congregate and determine level of consciousness using AVPU. Get your vital signs. Remember that normal sickle cell crisis vital signs are normal to rapid respirations, pale clammy skin, and low blood pressure. Use a pulse oximeter if available to measure oxygen saturation, and remember that the reading may not be accurate because the patient has an anemic state. Reassess your patient. Reassess vital signs frequently to determine changes in the patient's condition. Are there changes in mental status? Are the ABCs intact? Provide the indicated interventions and reassess. How has the patient responded to any interventions you've already done? Do I need to make adjustments? Hospital care for sickle cell crises may include pain management with analgesics, penicillin for infection, IV fluid for hydration, and blood transfusion, depending on how bad the condition is. Hospital care for hemophilia may include IV therapy to treat hypotension and transfusion of plasma, and you need to coordinate your communication and documentation with your receiving facility. Emergency medical care for hematologic disorders. Mainly, we support these patients and treat their symptoms. If patients have inadequate breathing or altered mental status, we should give them high-flow oxygen at 12 to 15 liters a minute, put them in a position of comfort, and rapidly transport them to the hospital. In summary, the endocrine system is a complex message and control system that maintains stability in the body's internal environment called homeostasis. Type 1 and Type 2 diabetes are metabolic disorders involving abnormalities in the body's ability to use glucose for fuel. Polyuria, frequent plentiful urination, polydipsia, frequent drinking to satisfy continuous thirst, and polyphagia, excessive eating due to cellular hunger, are common symptoms of the 3 Ps of uncontrolled diabetes. Patients with diabetes have chronic complications that place them at risk for other diseases such as heart attack, stroke, and infection. Hyperglycemia is a result of a lack of insulin, which causes excessive amounts of glucose to remain in the blood. It must be treated at the hospital. Hypoglycemia is a state in which the blood glucose level is below normal. Without treatment, permanent brain damage and death can occur. Diabetic ketoacidosis is the buildup of ketones and fatty acids in the blood and body tissue that results when the body relies upon fat for energy. Hyperglycemic crisis or diabetic coma is a state of unconsciousness resulting from DKA, hyperglycemia, and or dehydration due to excessive urination. Hypoglycemic crisis or insulin shock is caused by insufficient blood glucose levels that we need to treat quickly, give oral glucose if your protocols allow, to help avoid brain damage. When assessing diabetic emergencies, you should err on the side of giving oral glucose if protocols allow it. Do not give oral glucose to patients who are unconscious or who cannot swallow properly and protect their airway, and in all cases provide rapid transport. Problems associated with diabetes include seizures, altered mental status, intoxicated appearance, and loss of a gag reflex, which affects airway management. Moving on to hematology, hematology is the study and prevention of blood-related disorders. Sickle cell disease is a blood disorder that affects the shape of red blood cells. Symptoms include joint pain, fever, respiratory distress, and abdominal pain. Hemoglobin A is considered normal hemoglobin. Hemoglobin S is considered an abnormal type of hemoglobin and is responsible for sickle cell crisis. Patients with sickle cell disease have chronic complications that place them at risk for other diseases, such as heart attack, stroke, and infection. Most often, however, you will be called on to treat acute complications of severe pain. Patients with hemophilia are not able to control bleeding because clots do not develop as they should. Emergency care in the pre-hospital setting is supportive for patients with sickle cell disease or a clotting disorder such as hemophilia. Hope you've enjoyed the lecture. If you have questions about any of the hematologic and endocrine disorders, please bring them to class to discuss with your instructor. Thank you.